Welcome back to the Atlas of Chiropractic podcast. This is going to be our deep dive on somatosensory tinnitus. Now, the way this came about was I posted a reel from a previous podcast focused on a symptom and, put a poll out. What other types of symptoms would you like to see a research review on? So Kendall Merrill, a shout out to Kendall, suggested tinnitus. And so this is one of those symptoms that talked upper cervical chiropractors. What you'll find is the results are all over the place. Some people say they do really great with it. Other folks say they struggle with those symptoms. And so I think for me, it was one of those symptoms that I didn't quite understand exactly who would respond favorably and who wouldn't. And the more I've learned about anatomy, physiology, neurology, neuroscience, how these different symptoms relate to the cervical spine, I'm getting better at predicting those outcomes. And somatosensory tinnitus is one of those subcategories of a symptom that is basically directly in our wheelhouse in terms of who's going to have the biggest therapeutic impact on this for folks. And so as we dive into this information, two things. If you're listening to the audio only, you're going to want to go to YouTube and check out the Atlas of Chiropractic there. Subscribe. You'll see the presentation. There's going to be visuals associated with this one. Listening through is going to be good enough. You're still going to get the main takeaways, the clinical pearls, as it were. And I do have a companion guide that you'll be able to access. It's a PDF of all the relevant information, as well as full text links to the reference articles. So if you're listening, just get this first listen through to orient yourself to the topics. Go back, watch the YouTube videos so that you can see the companion visuals, and then read the papers and peruse the clinical companion guide for yourself. I'll show you and or explain to you exactly what that entails. But the whole point of this was to, rather than just kind of talk through a couple papers real quick, let's actually flesh this out and make it actionable for upper cervical chiropractors to be able to apply the key takeaways, at least my takeaways from my read on these papers, and see if they apply to your patient population in practice too. So without further ado, that's the direction that we're headed here. And so I want to first start by identifying some terminology. You heard me say tinnitus. Some people say tinnitus. Last time I sat with an audiologist, shout out to Dr. Iliff at Hearing Associates of Colorado. She used tinnitus, so that's going to be my pronunciation going forward. But as the name implies, somatosensory tinnitus is a sense of ringing in the ear that is derived from a somatosensory input. So this is interesting in that there is a cervicogenic subtype. And for folks with chronic tinnitus, this makes up 25% of those cases. So very common. And as we'll see going through our research articles here and some clinical takeaways, mechanistically, it's linked to upper cervical dysfunction. That is the source of this symptom. And as far as outcomes, it's most responsive when combined with education and central sensitization awareness. And when I say most responsive combined with, that's in addition to manual therapy. So key thing to consider as we're going through this here, and I think it's also something you're going to want to communicate when you're talking with patients that are experiencing this. This is a neuromusculoskeletal disorder with auditory symptoms, not an ear disease. Okay, so when you're dealing with folks that have Meniere's or vestibular conditions or sensory neural hearing loss, or they've got other cochlear reasons or ear-related reasons for their tinnitus, we're not talking about those folks. We're talking about folks who none of those other diagnoses and frameworks apply to, but they still have this symptom that's aggravating and driving them crazy as it relates to a neuromusculoskeletal dysfunction in the upper cervical spine. So what we're going to tackle in this clinical review is how to know it when you see it. What are the hallmark signs and symptoms and clues in the history? What are some of the important differentials that you want to consider? Assessments to confirm and monitor the progression of the symptom as you're going through care, how to adapt upper cervical outcomes towards a specific condition, treatment planning considerations, and I even put together a sample referral form here at the end so that if you were motivated that you wanted to see more of these folks and provide a solution, and connecting with audiologists and ENTs in your community would be that much easier. So that's the direction we're headed through the course of the presentation. And I think a good place to start would just be to show you the reference articles You're going to want to read these for yourself. I'm going to give you my takeaways. I'm going to apply some logic based on how these articles relate to upper cervical practice. And there's three studies that I use to kind of put this information together. One is a two-part series, and then there's a third companion study. So part one, cervicogenic somatosensory tinnitus, an indication for manual therapy. Part one, theoretical concept. Now, I'm going to scroll down to the very end here. And this was a publication in Manual Therapies. And this is where the rubber meets the road in terms of how does the neck affect tinnitus? And there are some really interesting neurophysiological mechanisms. But again, we have somatosensory input from head and neck structures. Now, these inputs are basically dumped into nuclei in the brainstem. Those correlate with other auditory inputs. And if things are going according to plan and normal function, there's no tinnitus. So, some of the relevant structures, we've got cervical nerves from C1 and C4 to C4 on the neck side of things. On the head side of things, we've got cranial nerves, 5, the V1 distribution of the trigeminal nerve. We've got the facial nerve. We've got glossopharyngeal and vagus. All of these nerve structures are projecting afferents into the medulla and the brainstem. There is a associated nucleus, the dorsal cochlear nucleus. This is a sub branch of the nuclei related to auditory input. And interestingly enough, the role that the inputs or the afferents from these head and neck neurological structures play is an inhibitory role. And so essentially what we have going on in these folks with somatosensory tinnitus is a disinhibition of the dorsal cochlear nucleus. A fancy way of saying we've lost a modulating effect. The afferent inputs coming through these structures is supposed to dampen or at least subdue outputs from that dorsal cochlear nucleus. So when we have dysfunction feeding either poor afferents in or not strong enough afferents in to inhibit the dorsal cochlear nucleus, that tinnitus is allowed to run out of control. So that's a theoretical framework that we're working with in anatomical and neurophysiological terms. So go read the paper, dive a little bit deeper into the details there so that you're firm on the theoretical construct. That way you can communicate simply. So that's part one. The second paper here is a complement to the first, which is Cervicogenic Somatosensory Tinnitus, an indication for manual therapy plus education. Part two, a pilot study. So this is where the theoretical construct becomes actionable, and we begin to test different manual therapy and or education strategies to see where the best outcomes lie. And so I will give you my takeaways from this paper as well as we go into some clinical application steps for upper cervical chiropractic. Third paper, this was from the Frontiers in Neuroscience in 2017, Pathophysiology, Diagnosis, and Treatment of Somatosensory Tinnitus, a scoping review. These types of review papers are great because they give us an idea of what's in the literature, and then obviously the references on these papers are rich with additional reads if you want to dive deeper and deeper into this topic. So those are our three reference articles. So back to our clinical companion guide here. Step one in this process always is identifying cervicogenic somatosensory tinnitus. But we've got to make sure that we're clear on what the patient's real problem is. You know, folks have a hard time describing these things to us. They don't always use the correct terminology, and they may have even had a, inappropriate or misdiagnosis in another office. So we've got to do our due diligence. Just because folks come to us with a label doesn't mean it's accurate. In addition to the side and or quality of the symptom, we've got to screen our tinnitus patients for some additional signs. Number one, neck pain, right? That's like every single person that comes into our office. Number two, impaired cervical rotation. Again, dime a dozen in terms of upper cervical patients. Number three, this is where it gets interesting. Increase or decrease of tinnitus with head neck movement or postural change. Now, this is that modulation component. And this is where we start to connect the dots a little bit more strongly between those afferents and those structures we referenced from our articles to the actual production of the symptom. And then lastly, tenderness of cervical and occipital musculature. Again, every single patient we see. So all four of these positive, meaning they're present with the symptom, strongly suggests cervicogenic somatosensory tinnitus in exclusion of other reasons for the symptom, right? So they may have normal audiometric testing, no hearing loss, no other reason to explain the symptom that they're experiencing. Obviously, those things are all topics of conversation in an intake, in a review of systems, and just discussing with the patient the reason for their care. They may not seek you out for this problem in particular. These folks oftentimes have headaches and dizziness and the other things we see too. So if you have on your intake form, somebody checks the box for ringing in the ears, let's dive a little bit deeper and see if we can have a better understanding of what is likely to occur under the course of our care with this particular symptom. Now, if someone did on an audiology referral come to you for this problem, you're still going to want to go ahead and verify through the presence of those four things that that's most likely what you're looking at. Step 2, assess for tinnitus sensitization. Now, this is not a diagnosis per se. It's more of a construct to help understand when it's not just a result of the peripheral tissue, not just the noxious stimuli coming from these bits and pieces in the body, but we've actually got central mechanisms that are kind of winding this whole thing up as well. And this is parallel to, let's say, central sensitization and has a lot of similar features. So you're going to look for things like widespread pain, allodynia, right? Things hurt that shouldn't hurt. Light touch registers as pain. Headaches, dizziness, visual disturbances, burning eyes, stress-sensitive tinnitus, sensory hypersensitivity, limb paresthesia. These are just a few of the things listed in our research references that you want to look out for as far as central sensitization features that may be influencing this tinnitus symptom, on top of the noxious afferent stimuli coming from the body parts themselves, right? And the way you might explain that to a patient is, listen, I know that this symptom's driving you crazy, along with a lot of these other things going on. I think, unfortunately, you've got it coming at you two ways. You've got some dysfunction in these body parts that are supposed to inhibit this experience, this sensation, this sound in your ear. On top of that, you've got some neurological things going on that are probably making it that much more sensitive. So depending on how things go, we can develop strategies to address both ends of those spectrums. We obviously want to do the best we can to take care of your neck so that we can tone things down on that end. And there are other strategies that can be really, really impactful on helping regulate and modulate some of the sensitivity in the nervous system, which will be good for the symptom, but also a lot of other things too. So we'll come back to that later in our care planning because we're going to kind of tackle both of these similarly, but slightly different, meaning if it's just peripheral somatosensory tinnitus, cervicogenic tinnitus, versus cervicogenic tinnitus with this sensitization flavor to it. And it's a really good time to just go ahead and say, like, what is the textbook classic presentation of this? And then what are some other differentials that we want to watch out for that are not going to be successful? So clinical pearl here. If a patient can say, when I turn my head, I clench my jaw, or I press on some tissue in my neck, the ringing changes, that is somatic modulation. If that's a change in the quality of the symptom, either the pitch or the loudness, based on just stimulating those structures in the head and neck region. And again, you tell the patient, you know what? This is one of those weird situations. You're not dealing with an ear disease. You're dealing with, and use this terminology, however you see fit, with a brainstem integration disorder driven by cervical afferents. That's doctor speak. What you might say to a patient is, you have a neck problem that's causing an ear problem. And it's a little bit counterintuitive at first, but give them the sciatica example if you need to. Hey, when folks throw their back out and pinch a nerve and they get sciatica, they got pain and numbness and tingling and weakness in their leg or their foot as a result of a problem in the back. Same type of deal. There's all kinds of weird sensitive structures in this head and neck region. And when there's irritation, when there's issues, all of the symptoms are in the head and neck a lot of the time. And so you can help folks connect those dots and understand a general physiological rationale that is sound without it being you've got a bone out of your neck that's pinching on a nerve causing ringing in your ears. Don't tell people that. It's not true. It's also not the most elegant way to connect the dots between how the upper cervical spine affects these conditions. So on our differential chart here, and this is pulled from the scoping review paper, we've got basically 4 columns here in 3 categories. We've got our green flag column. That's cervical somatosensory tinnitus. That is this clinical phenotype that we're describing. We've got peripheral or cochlear tinnitus. This is, again, a peripheral problem. So it's a problem with the cochlea itself that is very unlikely to respond favorably to neck work. It may, but it wouldn't be something that I would say, you know what, this is probably even being made worse by your neck. And then we've got our primary central tinnitus and our vascular objective tinnitus. These are red flags. These are not going to respond favorably to upper cervical chiropractic, even if a lot of other things do. So if they fall into that category, you're just going to tell them, look, this isn't one of those symptoms that's related to your neck. And certainly you want to make sure that you're clear on which category they fall into so that you can communicate properly. Upper cervical adjustments are not a cure-all or a treatment for every little thing. So you just kind of need to know which column they're in so that you can tell them what to expect. You're still going to get phenomenal results here, with X, Y, and Z thing. But in this case, with cervical somatosensory tinnitus, the typical patient profile looks like this: younger or middle-aged, neck trauma history. They've got posture-driven symptoms. They often will lead with, it's so weird when I move or hold my head this way. If I push there, if I eat or I chew something sticky, that's when it gets worse. They're basically leading you to the diagnosis. And a diagnostic hallmark is that it's reproducible with those maneuvers. Whereas something like a peripheral cochlear tinnitus might be an older patient. They've had noise exposure that doesn't change with any of these head, neck, or jaw stimuli. They may or may not even have a history of cervical spine trauma. The mechanism is damage to the hair cells in the inner ear, noise trauma, ototoxicity, right? Not something musculoskeletal driven. And in the primary central tinnitus, you're talking about brain-based neuroplastic changes in the auditory cortex, less likely to be impacted by upper cervical adjustments. And then on the vascular side, obviously, if you're dealing with pulsatile tinnitus or folks that have vascular findings, you really want to be clear on what's going on with the neck, how likely it is to be a safe and or successful situation. And again, study this chart. I'm not going to read the whole thing off to you there. It's in the paper. And if you're listening through in the companion guide, you'll have eyes on this chart and it'll really help demystify. If anything, just understand exactly what cervicogenic somatosensory tinnitus looks like. And if what you're hearing from the patient doesn't look like that, you're probably not dealing with it. Okay. So let's say we've done that part of it, right? We've identified the clinical phenotype of cervicogenic somatosensory tinnitus through our history and review of systems. It's time to move on to our physical exam procedures. We want to verify that this is what's going on. And our papers that are guiding this presentation are going to help us do that. First, a disclaimer: symptom-specific physical exam procedures augment your chiropractic procedural exams. And this is true for any symptom, right? You're going to have your baseline exams that you use to assess the function of the upper cervical spine, your imaging, your neck care, whatever it may be. And then you're going to add on additional physical exam procedures that are symptom-specific depending on the patient's presentation. Now, what we want to do is correlate multiple findings across several exams to build clinical confidence, aid in clinical decision-making, and monitor as care progresses. So somatic modulation testing, we've kind of hinted at this, but basically what you're going to do is perform body maneuvers that should influence the symptom, whether it's cervical rotation. You could throw in there lateral bending or flexion extension, jaw clenching. You could do protraction, retraction of the mandible, SCM and suboccipital pressure. So palpate these structures of the neck that are known offenders in this situation, known sources of potentially noxious or inappropriate afferent input. And then do postural challenges. What happens when you slouch, shrug your shoulders, bend forward, right? You can do different maneuvers to try to trigger a change in that symptom. That's what modulation means. And so as we're altering these somatic inputs and we're seeing a change in the loudness or the pitch of the tinnitus, we're zeroing in on what things need to change in order for that symptom to go away and stay away. Now, this is where correlating your chiropractic exam findings is really important because, let's say that it's a jaw clenching provocative maneuver, and we're not even going to cover the TMJ portion of this, but there's a huge impact that the TMJ has through those trigeminal distributions. Some of those situations may be less neck related. When you're doing your somatic modulation testing, you're then going to filter it through your chiropractic exam findings because those are the things that you're going to take action on your adjusting table and in your room. So do the listings on imaging, do the postural distortions that you're observing correlate? other inspection, palpation, or orthoneuro findings? Or can you stack the deck in favor of, you know what, if I adjust the spine in this way, it's going to improve on the functions that are exacerbating this symptom, and we expect that symptom to get better, right? It's about stacking findings. You don't want to have just one thing that says, okay, well, just because we could, bend your neck funny and cause it to ring, that means my little tap on the side of your neck with an instrument that doesn't even touch you or whatever is going to cure that. Let's not say that. Let's say, okay, we understand that you've got a head tilt in this direction. You've got alignment findings in that region of the spine that are resulting in this type of a breakdown in your movement. And when you stress that movement, it makes your symptom worse. So as we adjust you, we're going to influence that movement for the better. We're going to see the spine slowly realign over time. And as we work back towards normal function, we'll get to the point where the inputs coming from the neck are not so irritating, and that symptom will start to go away on its own. And any of you that have treated these patients, knowingly or unknowingly, you know that like they're going to feel better either right away or not at all, right? So if it's a somatosensory tinnitus situation, first couple adjustments, even if they don't understand all the mechanisms, they're going to know that the neck is involved, and they're going to notice a difference really, really early on. So the goal of an evaluation, again, is to correlate findings from your somatic testing and chiropractic exams, make sure it makes sense across a variety of domains, identifying functional deficits that can become objective goals. We'll talk about treatment planning and intervals for reassessments, but you don't want the symptom to be the only outcome, right? We know that. That's a fool's errand. So you want to have other measurable functional things that are going to be good for their long-term spinal health that we can also correlate to the symptom. That way, as we're progressing through care, we can make sure, number one, we're actually doing the right things for the spine, and number two, that the symptoms are progressing the way we'd expect. And then you're going to document these findings for coordination of care, whether it's to thank the audiologist for the referral, whether it's to coordinate with an ENT if things don't get better. It's good to document the functional improvements along with the subjective feedback that you get from the patient, that we leave a clear paper trail of exactly how things played out in your office. So when we're talking about upper cervical care strategy, I think it's important to say, and this is not just for somatosensory tinnitus, right? Adapting the delivery of care for any symptom, and this is no exception, it's not about treating the symptom directly. It's more about navigating the symptom response according to the patient's individual situation. Okay, so you're not going to go adjusting differently per se just because you're trying to like chase the tinnitus out. But we want to do as much as we can to make sure that our inputs are effective across multiple domains, right? So step 4A here, upper cervical care strategy. And this is just peripheral somatosensory tinnitus. We'll go in 4B here, talk about what do you do when they have that sensitization. But number one, deliver precise upper cervical corrections aimed at restoring C1 and C2 biomechanics. Upper cervical chiropractic is purpose-built to fix the problem that is causing this from a neuromusculoskeletal and mechanistic perspective. We got to reduce abnormal afferent input to that dorsal cochlear nucleus. We need to allow it to inhibit that signal again so that the tinnitus can be subdued. Additionally, you may address cervical muscle hypertonicity and or TMJ dysfunction when present. And these, again, are things that came up on your history and physical exam. Let's say a patient's holding, but they've had, this postural head tilt and the SCM's tighter on one side. You may advise on a stretch or do some trigger point work, or you may develop strategies for these other tissues outside of just adjusting. And that depends on your office procedures, flows, skills, all that sort of thing. But that falls squarely into the peripheral somatosensory tinnitus camp. Now, when folks have this central sensitization phenomenon, this tinnitus central sensitization, it's much like fibromyalgia and all these other central, pain situations. It's a little bit more involved than just moving the bones. So how are we going to handle this? In addition to everything that we do in step 4A, our precise upper cervical care, working on those other tissues as needed, we're going to also consider autonomic regulation strategies. How are we going to help these folks deal with the physiological effects of stress? That depends on, a lot of things in their lifestyle and their health status, your knowledge and skills. You may loop in some other therapies or providers to help with that. This is where the education comes in. Neuroplasticity and pain science education within a tinnitus framework is really helpful. It'll help folks understand why things are so sensitive, even though the problems with their body aren't so severe. And that's something that's really hard for folks to wrap their head around. This is where you got to be really mindful of your communication. You don't want to reinforce to folks this idea that you're broken and there's a problem with your brain and there's a problem with your neck and all this kind of stuff. You want to help them understand that a lot of things that are functions of the nervous system are more like electrical problems. And sometimes, in your house or your car, you have these little electrical short circuits or these little gremlins, some people like to say, where nothing's damaged, but it's not working right. It needs to be troubleshooted, it needs to be recalibrated. And that's the kind of situation that you're dealing with. So, we're also going to want to consider graded exposure to help desensitize folks, especially if noise exposure is ramping things up or stressing them out and making those tissues extra tight, right? We want to decrease anxiety and sensitization through habituation. So that's basically frequent small doses of exposure to irritating factors or environments. They've got to be able to tolerate a little bit of the things that are setting them off, but not so much that it's overwhelming their system. It's like fitness. You got to be able to push a little bit. You got to stress a little bit and then adapt to that stress to gain fitness. Similar with this idea of graded exposure. Now, these may be things that you do. These may be things you refer out to, things like EMDR and other types of pain science education platforms are out there. There's apps for that. You've got therapists, you've got PTs, there's occupational therapists, functional medicine, functional neurology. I mean, the Rolodex of folks that we work with that might be able to help on this side of things is pretty deep. So, make sure that it's a team effort. And back to our prior steps, you're documenting, you're coordinating care, and you're, making sure that everyone's on the same page with how the patient's care is being managed. And guess what? Sometimes the symptom still just doesn't respond the way you'd expect, right? That's why we didn't tell people from the beginning, I'm going to cure you with my magical upper cervical adjustment, right? We're setting expectations properly and we're going to communicate effectively. So, regardless of how the symptom responds, communicating honestly and helping the patient navigate this confusing physiology creates value in with not just your practice, but with you as a member of their healthcare team and leaves folks with a positive experience of chiropractic. There's nothing else that we can control, right? Besides our actions and habits in that direction. So, on the patient education front, as a part of our, treatment planning considerations, we want folks to understand that this is a cross-modal auditory somatosensory integration issue, right? So, what does that mean? It's brain body stuff, man. We've got all of these reflexive loops. We've got all this electrical communication between the body parts and the brain. And sometimes things get scrambled and screwy. And that's how symptoms like this can come from. So, the best thing we can do is get the body working better, keep a close eye on those symptoms, manage triggers, identify patterns of things that are not responding to our care, and then develop a strategy for those too, right? These are things that you can communicate to your patient. Reinforce that tinnitus is often a brain driven perception maintained by cervical input and stress related neuroplasticity. Again, this is not a problem with your brain, it's a misperception. It's hearing something that's not really there because all of a sudden, the neck is being grumpy and it's not dampening or inhibiting or putting the brakes on this perception like it should. And this is where we need to be mindful of nocebo inducing language. And we did a podcast on the neuroscience of nocebos. There's plenty more talks on how harmful language can be if used inappropriately. And so you want to, choose your words wisely. Patient education in this context is not say the right things on their way out the door so that they stay, pay, and refer. We're talking about actually empowering the patient to gain an understanding of not just their neurophysiology, but the role that your care plays in the long-term health of their spine in a context that's unique to their individual situation. So for general care planning and reassessment, this is at least according to the research. I think you'll find this parallels a lot of other neuromusculoskeletal conditions. You're going to want to reassess your outcome assessment tools and modulation testing every 4 to 6 visits. Now, there are specific codes for this. There you can download and use the THI, the Tinnitus Handicap Inventory. You can use a VAS scale, a visual analog scale for both loudness and annoyance of the symptom. But either way, you're going to want to have something that the patient can report and compare to through the course of care. It's so hard to know how something sounded in your ear 3 months ago, right? Like you've got to have a way to make that objective and documentable, if that's even a word, so that you can go back and compare. Now, typical clinical response apparently occurs over the course of 8 to 12 visits. So you're going to reassess every 4 weeks to track progression. Now, this is, genuine manual therapy for a lot of neuromusculoskeletal conditions. Your care planning strategies may be different, but again, if you're managing a cervical tinnitus case, these are best practices, and you may want to modify or at least overlay these recommendations on your traditional chiropractic recommendations. I think it makes sense what they're laying out based on my experience treating these folks. And then what do you do if it doesn't respond? Their neck is going to get better. Like with what we're doing, you're doing functional good for the cervical spine. So you can facilitate that referral if you've reassessed and you know what? Things with the neck are trending in the right direction. This symptom is just more persistent than we want it to be. Something else is going on. Back to your history and physical exam and review of systems and all that sort of thing. If you know that the TMJ or jaw is a potential driver, you've already got, that set up. Hey, we're at the point now where we're doing the right things by the neck. We're going to see that through to completion. But for the sake of this symptom, I think it's a good idea to, let's tag in a neuromuscular dentist to have a good look at that jaw and see what the role is there, right? I mean, totally reasonable. And whether it's an ENT, an audiologist, or neurologist, that's your clinical doctoring that you've got to do to kind of help identify which referral makes sense and then facilitate and communicate with that referral. And again, document the response to care, request follow up notes for continuity of care, make sure you understand what's going on the other end of that referral. And I'll just say that it's not bad to document a lack of response to care, right? We don't have to always fix everything. We have this idea that like we're admitting failure if we send someone to an audiologist for audiograms and say, hey, we've done 4 to 6 weeks of conservative care. They're progressing in all of these ways. This symptom is not breaking. And so we want to get a deeper dive on what's going on there. I mean, that's honest and it's in integrity and it's totally fine. I mean, patients and providers alike don't expect you to fix everything, but they do expect you to know what to do if things aren't getting better. And so, speaking of, I threw together a quick sample referral form, right? And you could create these for a variety of different conditions, common conditions that you see in your office. And this is something that you can, use as a way to build a bridge between you and audiology clinics or ENT clinics. Help them understand that you are trustworthy and knowledgeable. You understand this condition. You know how to properly assess and treat folks in these diagnostic categories. You're collaborative in your mindset. You want to work together. And this is something that, you brand your way and you can demonstrate your mastery of this topic because you've read the papers, because you listened to the Atlas of Chiropractic podcast, because you studied the companion guide, you've gained clinical insights, you've had success with patients, you've communicated effectively, you've really done a good job with these folks, then the trust is there for the referrals to come your way and then to, reciprocate those referrals as well. Awesome. If you've been hanging with me this far, I hope that encouraged you to take a look at these 3 papers, read them for yourselves. There may be some other takeaways that you come away with as you filter that through your own personal experience. But I hope you found that helpful, actionable. To get the clinical companion guide, you got to follow a couple steps. All right. I put a lot of time into this stuff and I want you to have some skin in the game to get it. So follow the Atlas of Chiropractic on Spotify. Make sure that you're getting on Apple Podcasts or wherever you listen, you're getting notifications when new episodes drop. Number 2, share this episode on Instagram. Tag at Zenith Chiro, tag at Dr. Bearder. Our links to our social profiles are here in the show notes. Show that you're listening, that you're seeing, that you're sharing with your community of patients and colleagues. And then we will acknowledge that and send along the clinical companion guide PDF along with the 3 papers to read for yourself. So if you found that interesting, I think I'm going to do more of these in terms of, symptom specific content that goes a little bit beyond patient education in terms of, do you have this symptom and all your tests are normal? Come get your neck adjusted. I'm not talking about that. I'm talking about a deep clinical dive that helps empower you as a doctor to understand, to communicate, and to treat patients effectively. And thanks as always for your time and the dedication of your attention to the Atlas Chiropractic podcast. We're here to help make you a better doctor along with us, and we do appreciate you lending your ear and listening.